Okay, as much as I can. I'm recording now. I didn't see, he should have spoken up as well once he had written. Anyway, all right. So what should be the, okay, what are the lumbricals which are supplied by the ulnar nerve?
Medial
Third and fourth. Medial.
Okay.
Lumbrical 3 and 4 with medial 1.
What about the median nerve injury?
High median nerve injury, low median nerve injury, high will result in ape deformity and Siamese hand, and low will result in carpal tunnel
Yes.
symptoms like
Median nerve
thenar
injury
wasting.
at wrist. That will present.
Yes, ma'am. The result
yes.
in wasting of thenar muscles and problems in the sensory distribution of thenar. That is the later 3 fingers and thenar, over thenar.
Yes.
No, there is no going to be nerve distribution damage because superficial palmar supplies palm, that the surface of the palm. Apart from that, there will be.
Sorry, Atya?
Superficial palmar branches before passing through carpal tunnel. So there will be no loss sensation over the palmar surface of thenar.
Tell me everything. Question is, network is slow or what? Everything is taking so much time. All right, next one is about thyroid. Tell me about everything about thyroid. What is the blood supply of thyroid gland?
Inferior and
Will be
thyroidema.
yes. Right lobe, left lobe, and isthmus. And these are supplied by, what are the blood
Superior
supply?
thyroid, middle thyroid, inferior thyroid.
Yes.
Inferior thyroid arises from the thyrocervical trunk, and superior arises from is the first branch of external carotid artery. And
Yes.
the venous drainage is also superior, middle, and inferior. Superior and middle go to the internal jugular. Inferior one directly drains into brachiocephalic. Then thyroid, most commonly divided structure during tracheostomy is thyroid isthmus. And about CA's 4-type papillary is the most common one seen in young people, and most aggressive is the anaplastic. And follicular spread is by hematogenous, papillary spread is by lymphatic. Medullary carcinoma
is it bilymphatic in all cases?
In follicular, ma'am. No,
Okay.
in papillary,
No. In papillary, it's
Papillary.
lymphatic, and in
Yes.
follicular, it's hematogenous.
Yes, it's hematogenous.
And medullary also lymphatic.
Okay.
Mainly.
Yes, mainly, yes. She's correct. All right. Which carcinoma of thyroid presents most aggressive on diagnosis?
Anaplastic.
And seen in what age group?
Older
70
age
to
group.
80. 60 to 70. 60 to 70.
Older age group, okay. So which one is most difficult to be diagnosed on fine needle?
Follicular.
Yes.
It's follicular.
Yes, so adenoma and carcinoma, it's difficult to be diagnosed. Okay, in which condition would you see when, yeah, okay. Descent is, but there was one question about the descent of thyroid because it descends through the
Foramen cecum. Thyroglossal tract.
Foramen cecum
yes.
to then up to hyoid it comes.
Yes.
There's thyroglossal cyst.
So if we treat the thyroglossal cyst, we'll have to remove the whole tract extending from the cyst trunk operation.
Fail to remove the whole tract will present with what kind of presentation?
Again, infection and discharge.
Recurrent infection.
Infection and discharge.
All right, now this another 37th one is about the treatment. What treatment options are available when it comes to thyroid?
If it's
total thyroidectomy.
Yes.
If it's carcinoma, If it's carcinoma,
Yes.
in papillary, if less than 1 centimeter, hemithyroidectomy. If more than 1 centimeter, total thyroidectomy. In follicular, we do usually total because it's diagnosed by lobectomy first, and if it's it depends on institute. If they think the margin clearance is enough, they sometimes keep it like that, and if they don't think that margin clearance is not enough, then they go for total. In medullary, it's total, and
Please
anaplastic.
repeat.
Sorry.
Please repeat.
From where?
From thyroidectomy.
Thyroid
Okay.
treatment options. Thyroid
Okay.
treatment options.
In papillary, less than 1 centimeter, hemithyroidectomy. More than 1 centimeter, total thyroidectomy. In follicular, we diagnose it by lobectomy, and if the margin clearance is enough, some institute go for that, they don't do anything further, and some institute they go for total, and if the margin clearance is not enough, then go for total, they go for total thyroidectomy. In medullary, we go for total thyroidectomy. And in anaplastic, we don't do anything like surgery, we give maybe chemotherapy, and if the patient develops distress like respiratory distress due to compression, we only cut the isthmusectomy to relieve the respiratory distress. And lymphoma also chemotherapy.
Ma'am,
Yes.
what is the answer of that? 37.
I have not. Okay. There are no on replacement T3 and the table with what you expect the thyroid picture to look like. So what would you, how would you expect it to be?
I expect normal TSH, normal T4, T3, and low calcitonin, I think.
Normal TSH or low TSH?
Our
Normal.
aim
Patient is taking, yes, on replacement.
Yeah,
T3,
but our
so
aim is to get the patient to normal. We don't expect it to to be low. Though it is said TSH suppression, but usually it's normal or maybe no, but not very low like hypothyroidism.
yes.
But here the whole scenario isn't given, ma'am. So how can we just
You
guess
can't.
it?
That's why when I ask you
Now,
everything.
usually
Okay,
what happened
5.5
after
to 6,
thyroidectomy, we gave replacement thyroxine.
Yes.
So that's why
Thyroxine
after
is
giving
T4, but here they are
thyroxine,
saying T3.
So what is the this hypothyroidism that you have brought it up, right? This can present with this can present how?
With
What I mean to ask that if there is a nodules present, does it have to be like I've forgotten the question. Anyway, I wanted to know if it will how it will spread. If there is
sorry, ma'am, I didn't get you.
sorry, I want to rephrase the question properly, but its words are not coming. I wanted to know if there is, because you know in thyroid enlargement can take place even in case of hypothyroidism,
Yes,
Hashimoto's
yes, ma'am.
thyroid.
Yes, ma'am.
Hashimoto's
Yes,
thyroiditis.
yes, that's what I wanted to ask you. So if there is thyroid enlargement and you do histology, what would you see?
In Hashimoto's, is there lymphatic infiltration in Hashimoto?
Yes.
Yeah.
This more
Lymphocytic
lymphatic.
infiltration.
Sorry,
Yes.
lymphocytic. Yes, sorry, lymphocytic.
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 Yes, this is what I wanted to ask you.
And there is some antibody.
Yeah, that is thyroid peroxidase
Thyroid
antibody
peroxidase antibody.
Yes.
in Hashimoto's.
And in case of cancer, thyroglobulin antibody.
But then treatment will not be surgery in that case. This is what you have to know. This is what you have how you have to rule it out. Then
steroid.
Yes, medication.
Okay.
And in case of what I have to ask you, all right. Okay, 38. If I've forgotten anything, please remind me, okay? Multiple
Yes, ma'am.
stones in kidney and made of calcium oxalate. In what kind of condition? Yes, primary hyperthyroidism. How is the picture in case of secondary hyperparathyroidism?
There will be calcium will be decreased
Yes,
and parathyroid hormone will be increased and phosphate
yes,
will be
phosphate.
increased.
Yes, very good. Okay, can you
No,
tell
it
me?
will be primary hyperparathyroidism.
Or primary
Ma'am, why not
hyperoxaluria.
hyperoxaluria? Yes, ma'am.
Yes.
It is hyperoxaluria because
Will you guys write it there?
it is not hyperparathyroidism.
It can be, isn't it?
Depends upon the
You
whole scenario, I think.
Yes, depends on the whole
Depends.
scenario.
Yes.
But usually
Because
All right.
stones, kidney
hyperparathyroidism,
stones.
Let me.
hyperparathyroidism
Yes.
don't have the pinpoint calcium oxalate stones.
No, doesn't actually. In all cases. Okay, what other kind of kidney stones are you aware of?
Calcium phosphate, and then endeavor and cysteine. Cysteine is seen in with the inherited metabolic disorders,
Yes,
family history of stone,
yes.
recurrent stone. And if there is recurrent infection with the stone and alkaline urine, then it's that one, sturvate, triple phosphate stones. And the most common organism is Proteus in that. And calcium phosphate and calcium oxalate are radio opaque. Endeavor is seen in people with the chemotherapies or HIV treatment and with antivirals.
What are the stones which are radiolucent?
Endeavor.
And
Uric acid one.
And
yes,
yes,
when
uric acid.
when do you have uric acid stones more pronounced or more?
In gout?
Yeah, and even patient taking chemotherapy, cancer patients, then uric
Yes.
acid level raises and these stones become more pronounced in that condition.
Yes, ma'am.
Okay,
yes, yes.
right.
Okay.
So HIV is radiolucent and indivinavir store, and uric acid is for
Yes.
chemotherapy. Okay.
Yes.
Yes, this is how little I know.
What did you
People
say,
are writing
Tasneem?
so much. Whoa.
That associated with indinavir, that one is radiolucent store in HIV treatment.
Okay.
And uric acid is also a radiolucent and it's associated after chemotherapy.
All right, skin lesion. It will be posted soon, hopefully. My network is very slow. I don't know why. The 39 one is about skin lesion. And what are the skin lesions which are purely lesions and are present at sun-exposed areas? It's not being posted.
Yes, it
WhatsApp
is,
is
ma'am.
very
It's posted.
slow.
Basal cell carcinoma.
We can see it, ma'am.
How?
Yes, ma'am. It's on the screen and people are answering.
No, they are
Maybe
not.
you're getting the answers late, maybe.
No, I have
Yes, ma'am.
posted it. Now they are answering. Okay. So what are the skin lesions that you are aware of?
It's
This
BCC
Basal cell
most
carcinoma,
common.
squamous
yes.
cell carcinoma,
How
and then
would you
melanoma.
differentiate
Basal cell is pearly and rolled,
purely? Yes. Rolled edges. Yes.
beaded appearance maybe, and
Okay.
occurs in this area from angle of eye to the angle of mouth in this area more commonly.
Yes.
And it's it's locally aggressive, but lymph node metastasis is lesser than squamous cell carcinoma, and SCC is more angry looking, and sometimes there may be keratin and there is everted edge in the SCC. And
Okay.
malignant melanoma is black or bluish in color.
Yeah. Okay. There are more. What this will come in more, not maybe in this one, but what are the genes which are involved in malignant melanoma?
What are
In
the
malignant melanoma,
Yes, please.
what is the question? Genes.
Yes.
That
It's
B
100.
RAF
That's
B100 something, you know.
S100 is for
yes,
it's the
ma'am.
Yes, 100.
immunohistochemistry. S100 is
Yes.
for immunohistochemistry, and the BRAF gene is associated with associated with malignant melanoma, which is used for treatment in malignant
Can you
melanoma.
write Tasnuba this one?
I'll have to find and write.
Okay. I'll post because I have it in my notes.
Okay, ma'am.
All right. Tell me everything about ear. External ear they are talking about in the middle. Okay. How would you
External
know
ear.
the difference between,
Yes, ma'am.
yes, Weber's and Rennie's test?
In Rennie's, normal is air conduction is more than bone conduction. So if
Yes.
it's normal, we will have any abnormality, we will have a bone conduction more than air conduction on the same side where there is a lesion in Rennie's. While in Weber, there is lateralization. And lateralization is, if there is a damage on the right side, I will hear better on the left side in case of a sensory neural loss. But in case of a conductive loss, there is going to be lateralization on the same side. So if I have a damaged nerve, if I have a conductive deafness on the right side, so there is going to be lateralization of on the same side. But if there is a sensory neural loss, there is going to be lateralization on the opposite side.
Okay. And now this one, lots of symptoms, but external.
I don't
ear,
get
yes.
this, ma'am. I don't understand
Me
this
too.
one.
Options included clostrostoma in this one patient. Okay. When do you see schwannoma? It's involvement of which? You've written in
Inner
moon and you're
ear.
telling me, Dr. Inmoon, you've written the answer. Middle ear.
Inner
Yes.
ear.
Inner ear. Involvement of which cranial nerve?
It's vestibular ocular nerve.
Vestibulocochlear.
Okay. And
There is sensory neural hearing
Yes,
loss.
yes.
The cochlea, and there is the disturbance in equilibrium.
Yes.
Tinnitus, vomiting,
Eight nerves.
increased
Yes.
raised
Headache.
hearing pressure, oral symptoms.
Okay. Yes. And there could be involvement of eighth nerve. Yes. That's why there is all these symptoms that you're talking about. Right. Manberg says, so this one presents with back pain, protruding something. So what are the conditions that can result because of this injury?
Because of
back.
what, ma'am? Sorry, can you repeat?
Yes, 41.
This 41. Is it, ma'am, hemorrhoid?
If it's a
Protruding something. See, this is like from backside.
Protruding.
Protruding is something coming out, right? So it could be like, yeah,
From
bleeding or something, hemorrhoids. Patient had
yes.
some cause of portal hypertension or something. But what I thought when I thought the patient is carrying heavy boxes, then I thought maybe this
Yes.
back pain and nucleus pulposus is
The
protruding out.
first
yes,
impression
ma'am.
with this question is like that, ma'am.
Yeah,
Like
but
carrying heavy box. But when they say that protruding
protruding,
from backside,
then you don't know.
so
Maybe hemorrhoids, yes, prolapsed. could be, yes, definitely. I don't know, because these are recalls, and this is the problem with recalls, that questions are not complete.
Yes, ma'am.
This 42 patient had
Inventoric
fever, yes,
abscess.
and could not tolerate DRE. So yes, this is abscess.
If there is no history of fever, then we will think about fissure. But there is a history of fever with intolerance to DRE. Then it's
Intolerance
abscess.
to DRE. So definitely,
Yes.
yes. All right. Can now that we are discussing this, can you tell me what stabilizes the internal anal sphincter? Or yes, what is the location of most common location of abscess formation in case of anal region?
Intersphincteric,
Okay. Yes.
40%.
Yes. Could that be associated with any other chronic illness?
Crohn's disease.
With
Yes.
Crohn's.
Yes.
Is this fistula or abscess the most common intersphincteric one you're telling, Atya?
Fistula
Abscess.
occurs as well, but abscess, yeah.
Okay. Because fistula also have 4 types, and most common is, I think, intersphincteric. That's
I don't know about the fistula. I only read about abscess.
okay.
Okay, 43. Bum again. Someone had an abscess, is now getting anal pain, occasional stuff leaking from bum. It's fistula.
Yes.
Yes.
Fistula.
Could be. Yes.
So how we can differentiate between fistula and abscess?
Come on.
Fistula has a leakage.
Yes. Tell me the definition of fistula. What is fistula? A
The abnormal
communication
combination
between, yes,
between
Abnormal
two
communication between
Yes.
epithelial
epithelial
yes,
surfaces.
yes,
and lined by the healthy or unhealthy granulation tissue.
yes. And this is abnormal. You yourself told me. And then what is abscess? Abscess is collection of
Localized
Pus.
collection.
and yes,
Necrotic duct cells.
Lined by a pyogenic membrane.
yes. So in case of abscess, there will be cardinal features present: fever, redness, warmth, etc.
Yes.
And then in case of fistula is a chronic, and then tract has been formed. So process is not
Yes.
acute.
Yes, ma'am.
And you, once you'll examine, then you'll definitely know the difference.
Yes, ma'am.
What is
Okay, 44.
cerebral edema?
Sorry, ma'am?
44, cerebral edema, what that is?
Something sounding similar to cerebral edema, what to do? Ma'am, for cerebral edema, we give both mannitol and steroids, depend upon which type of edema it is. For vasogenic edema, steroid is more responsive, and for other type of edema, mannitol is more responsive. So I'm not sure what question is, what are they asking about?
I don't know myself.
Usually, in case of brain tumor or brain metastasis, use their steroid.
Okay.
We use both, mannitol and edema both, steroids both hormone.
Okay.
It depends upon, when it's brain, we see what kind of edema it is on the basis of pathogenicity. Then it's responsive. Like if it's vasogenic, Dexa. If it's other, then you go for mannitol
right.
more.
Tell here,
Okay.
what would you do? 45.
Another
pressure
question
is raised.
saying,
Yes.
yes, ma'am. We will decrease carbon dioxide, because when there is increase in carbon dioxide, there is going to be vasoconstriction, which is going to increase the intracranial pressure. Decreasing the carbon dioxide will result in vasodilation and decrease intracranial pressure.
So these are the options.
Yes,
right. I
ma'am.
thought this is the condition.
So
Would
basically,
you or
carbon
would you
dioxide
not?
causes.
Yes.
Yes.
Yes, please.
Yes, ma'am.
Ask.
No, nothing, ma'am. You can tell.
Yeah, I was going to ask you if you are going to recommend mannitol.
Dr. Adya,
decrease intracranial pressure. Yes, please.
what about increase oxygen?
Oxygen is not the major determinant of cerebral blood flow. It's carbon dioxide there. So oxygen has nothing to do. Your carbon dioxide is going to determine whether your vessels are going to dilate or constrict in brain. So
Yeah, but
carbon dioxide is
oxygen
determinant.
should be
high
also
flow
at
oxygen.
11. No, not high flow.
Yes.
You have to maintain the partial pressure of oxygen of 11 at least, and carbon dioxide pressure should be 4.5 or less, not more than that.
Okay, would you or would you not recommend a mannitol for that patient?
Ma'am, for
No.
cerebral
Yes.
edema, mannitol is given. I can send the chart
Now, in
from
this
Delhi
condition, yes, I know. I'm just discussing
for
intracranial to lower intracranial pressure.
if the first measures like the patient's position, then oxygen, then carbon dioxide doesn't improve the intracranial pressure, decrease that, then we'll have to add mannitol. If these are not working, then we'll have to give mannitol. Even if mannitol is not working, we do that hypothermia and then that cranial what do you say, craniectomy to relieve the pressure. There are steps of management
Yes.
in
Yes, would
intracranial
you?
pressure.
Yes, would you add any other diuretic?
Furosemide?
No.
Yeah, can
Yes,
be.
it is Dynamite.
Yes, can be.
So mannitol can be given in this condition.
Yes, and then depending upon if you'll leave it alone or you'll add more diuretics in it. All right, okay.
46 pernicious anemia, and why?
Why
Antibody
it
to
happens?
intrinsic
Yes.
antibodies against parietal cells.
How does it present?
Macrocytic,
Macrocytic
megaloblastic.
Okay. Pernicious anemia leads to deficiency of something else as well or not?
Intrinsic factor
Very good.
deficiency.
And that leads to deficiency of
Megaloblastic anemia,
yes, very good.
decreased absorption of vitamin B12.
Yes. Okay. So my speed is very slow, right? People are getting tired, maybe. Not even we have done 50 yet. All right, pneumonia, but very soon after transplant, like months. Tell
Within
me
6 months,
about yes.
Within 6 months, CMV, and after 6 months, EBV.
All right, good. Yes, that's possible. Okay. Right, 48 one. What is the what is Dupuytren contracture?
It is a fibrosis and thickening of the palmar sternum.
What are the risk factors which lead to Dupuytren contracture?
Diabetes mellitus, hypothyroidism.
Yes. And
Hepatic disease.
is it or is it not related with rheumatoid arthritis?
Dupuytren contracture. I didn't think so.
How would you treat
Carpal
it?
tunnel syndrome. Carpal tunnel syndrome associated with the rheumatoid arthritis.
Okay. But all right. What should be the management of Dupuytren's contracture?
Initially exercise conservative and later release. Initially
Yes.
medical and then
Release.
surgical.
Yes. Lumbar puncture.
Sorry, ma'am. The answer is deep branch of ulnar nerve or superficial branch. I think it's superficial
Deep,
branch.
deep,
Deep.
deep. You did it wrong. I was supposed to tell you. Sorry, I forgot.
Okay, okay.
I
Sorry.
didn't even see. I was looking at deep, and then I didn't notice everything because then I have to copy and paste my own question as well. Okay. Lumbar puncture. Tell me, is done. What are the layers that needle pierces?
Skin, superficial fascia, and then supraspinous ligament, interspinous ligament, extradural space, ligament of flavum, and then arachnoid and subarachnoid space.
Okay. If patient is presenting with intracranial raised intracranial pressure, would you go for lumbar
We
puncture?
don't do
or-
LP,
Yes.
never.
Yes.
Coning, there
Why?
is a chance
Coning,
of coning.
yes, very good. When you're doing LP, in case of EMRCS, there are 2-3 ligaments which you have to pierce. Can you tell me from outside to inside which ones
There
you'll come
is
across and which one is the toughest one?
at first skin, subcutaneous tissue, superficial fascia, supraspinatus ligament, intraspinatus ligament, then ligamentum flavum. And the
Okay.
toughest one is the ligamentum flavum.
Flavum, yes, very
Yeah.
good. All right, can you tell me the boundaries of femoral hernia and the posterior relation?
Later, it is bounded by femoral vein, and medially it is bounded by lacunar ligament, anteriorly inguinal ligament, and posteriorly pectineal ligament.
Okay, and posteriorly? Did you tell me?
Pectineal ligament.
Yes, okay.
Yes, ma'am.
Right. What are the layers of femoral triangle? Not layer, the
Boundary.
not boundary,
Contents.
contents. Yeah.
Yes, ma'am. Femoral artery, vein, and femoral canal. Nerve is
Okay.
outside, and nerve also in triangle, but outside sheath.
Yes, and most medially is long saphenous.
Yes. Okay. What are the contents of femoral canal?
It's
It's
clogged its lymph node.
yes.
What forms the anterior boundary or the roof of the femoral canal?
Anteriorly, it is by inguinal ligament.
Okay. What
Or
is
is
the
it
yes?
posteriorly? Is it fascia iliaca or fascia
That
transversalis?
is
Fascia
for
iliacus
No,
that is for
anteriorly.
inguinal.
Yeah.
That in inguinal, the posterior boundary is by fascia iliaca and conjoint tendon, and in femoral, the posterior boundary is by popliteal. Both are different.
Both are
Pectineal,
different.
right? Okay, okay,
Yes.
Yes, for inguinal,
Pectineal.
pectineal, and for femoral, fascia iliaca, laterally, and medially conjoint tendon.
Yeah.
Okay. So tell me about the inguinal hernia, both direct and indirect. How would you know if it's direct and how to differentiate if it's indirect?
We did the deep ring test. If the deep ring
Okay.
test is occludes, it's indirect, and if the hernia comes through the posterior wall, it's
Yes.
direct.
Yes.
And usually direct hernia is incomplete, and indirect hernia is usually complete.
Okay. And which is seen in which case?
Inguinal hernia in congenital cases,
Is seen which one?
indirect hernia in
Indirect.
the
Okay.
Indirect hernia.
And in case of elderly,
it's direct more
Direct,
common.
direct one.
mostly.
Yes. Okay. Which hernia is more common in case of females?
It's
Femoral.
still inguinal. No, it's still inguinal.
Inguinal.
It's still inguinal.
Okay.
Femoral hernia itself is common in females, rather than
Females.
males.
Yes.
Rather than males, but in female, it's inguinal hernia is
Also,
more common than femoral.
Yes.
Okay.
Okay.
Thank you.
Right. So what's the most medial structure in cubital fossa? Tell me the boundaries of cubital
Meat.
fossa first.
Okay. It is formed superiorly by a imaginary line between the radius and ulna, and laterally it is by brachioradialis, and medially it is by pronator teres. And the most medial structure is medial nerve, then brachial artery, then tendon of bicep brachii, and radial nerve, then most lateral structure.
Okay. Tell me the relation of median nerve to brachial artery in the cubital fossa.
Artery is lateral.
Yes,
It's medial.
artery is lateral. Artery is lateral, median nerve is medial.
Yes, median nerve is medial. Okay, right. So, which vessel is more superficial in the antecubital fossa?
Median cubital vein.
Yes. What will not be damaged in tracheostomy?
Ascending pharyngeal artery, because it's
Good.
medial.
Ascending pharyngeal artery.
So when tracheostomy is done,
When we can't
indications
intubate the
of
patient.
Pharyngeal.
Any
Yes,
airway
when there is a
obstruction,
Yes.
when intubation is not possible, also in epiglottitis, and then foreign body lodged in the airway, also in some laryngeal tumor.
This
When
is
we
done
resect,
with hello.
yes,
Yes.
Yes.
we're all here. Just trying to, yes, drop my ears, what's happening outside. Yes.
What is damage in posterior triangle? Spinal accessory.
yes.
Most common damage now.
Okay, tell me the contents of posterior triangle first.
Okay.
The boundaries, please. First boundaries, and then
Posterior border. Yes, ma'am. Posterior border of sternocleidomastoid forms the anterior boundary. Trapezius anterior border forms the posterior boundary, and the middle 2/3 of the clavicle forms the inferior boundary.
yes,
It has subclavian, second part of the subclavian artery and external jugular vein, and among nerve it has cervical plexus, phrenic nerve, no, not the phrenic, spinal accessory and phrenic nerve. Yes, these all are there, and it has lymph nodes and
okay.
inferior belly of omohyoid, and there is one another muscle I forgot.
All right, that you can brush it up later on. All right, how would you diagnose or differentiate between upper motor neuron lesion and the lower motor neuron lesion of facial nerve?
Ask the
The eyebrow.
Ask the
patient to
patient.
raise the eyebrow.
Yes,
Yes.
good. What will, okay, you ask the patient to raise the eyebrow, and then what?
If it's an upper motor neuron lesion, the
Yes.
patient will be able to raise the eyebrow. But if it's a
Yes.
lower motor neuron lesion, they won't be able to raise the eyebrow.
Good. This is now the complete answer. Very good. Okay. Okay, right. The lady with the swelling in her groin appears on standing, it's reducible and has a frill. What could that be?
Saphenavarics.
Very
Saphenavarics,
good.
ma'am.
Okay. Why you said it's a sphenavarics?
Because
it
it's
reduces
reducible
and
and
has
it
a
has a
frill.
trail.
Very good. If it
I
was,
didn't hear anyone. Can
Sorry?
speak one and tell.
sorry,
Speak one and tell.
yes, Dr. Atia.
Ma'am, it is reducible and it has a thrill. That's
good.
why.
Yeah.
If
Tell
it
Dr.
was
Ilmun.
a pseudo-aneurysm, if it was a pseudo-aneurysm, it
Yes.
won't be. It would be irreducible, and they would have mentioned it. It's a pulsatile.
Very
There
good.
is a thrill in aneurysm too, but mostly they use the word pulsatile.
Yes, very good.
Yes.
Okay, and if it was,
Cough impulse will present in saphenavarics, which will not present
Yes,
in
it is
false
present in
hernia.
sometimes.
yes,
Yes. It is also present in hernia, but in hernia we don't have a thrill.
yes,
Usually
Yes.
femoral hernias are irreducible, and sometimes the cough impulse is
Yes.
absent in femoral hernia.
Yes.
okay.
Okay, 57 claudication question, but the pain was in thigh. Options regarding where is the stenosis include aorta, common iliac, internal iliac, femoral, and superficial femoral.
It could be
So-
common femoral or external iliac.
Okay.
Yes.
Why?
Because
the
the pain occurs below the level of stenosis.
All right.
Yes.
Good.
Ma'am, it's like this.
Yes.
If there is a buttock pain, then it's a aortoiliac. If there is impotence, that's also aortic iliac. If it's thigh pain, then it's common iliac or external iliac.
Common
If
femoral.
it's calf, yes, sorry, common femoral or iliac, external iliac, yes. And if it's a calf, then it's superficial femoral. And if it's if it's distal 1/3 of the calf, then it's popliteal.
If it is bilateral in buttock, in case of male patient,
That's
what is the
aorta
condition?
bifurcation.
yes, what is
Bifurcation
the
of the aorta.
condition called?
Leach syndrome.
Ledishes,
Yes.
Ledishes
Leach
syndrome.
Yes, very good. So 8-year-old child with noticeable lump coming from the buttocks and it's bleeding. What could that be?
Juvenile polyp.
Very
And
good.
they are hematomatous in nature.
Yes. How often are you going to do the monitoring or follow-up surveillance? Does anyone remember the routine? At what
Oh,
age
man.
will you? Yes. By the age of 12, you'll start. And how often?
16.
Oh, are you asking ma'am about the familial adenomatous polyposis?
Yes. Follow-up.
Yeah,
Oh, okay.
yeah, we'll start at 12 and then we'll do yearly follow-up up
Yes.
to 20. Then
20
after
years.
there is no polyp, then we'll go for 5 yearly, I think.
Okay.
If
Yes.
no, if nothing up to 30, then we'll discontinue.
Okay.
And we do the if we have the facilities to do the APC gene screening,
Yes.
we'll do that. If we don't have the facility, we'll look for the retinoscopy to look for the hypertrophied retinal pigment.
What if there is, if it's positive, and then what should be the treatment?
Sorry, ma'am.
Polypecto.
Yes.
It's
If more-
pan-proctocolitis.
Pan-proctocolitis.
Yes.
Yes. Yes.
And then regular surveillance by endoscopy to see if there is any duodenal tumor developing or not.
Yes. And tumor will most likely develop, then you will do the pan. Okay, what is the embryological origin of ductus arteriosus?
6
aortic arch.
Yes. Anything else develops from 6th aortic arch?
pulmonary
It's
artery.
right and left pulmonary artery.
Very good. Okay. Right. What is, all right, next, where is it? Hope to finish it soon. It's already 6. What does the urachus become?
Median umbilical ligament.
Okay. What is the, okay, this is medial, there are another term as
It's
well.
Medial umbilical ligament, which contains inferior epigastric artery.
Yes,
Yes.
very good.
There are 3.
Yes, there are 3. So what is the origin of muscles of facial expression?
Second arch.
Okay.
Second pharyngeal arrangement.
And nerve is facial nerve.
Yes. Is this Musa? Dr. Hina's
No,
baby?
this is illness.
Illness. Tasnuma's
Tasnuma's
daughter.
way.
Okay, good. The French girl. What is the
Yes,
effect
ma'am,
of?
and she's a very happy child.
That's good. That's good. Like my doctor as well. Is that it?
Yes, ma'am. She studies with us all the time.
She does. Okay, now she's saying hi. So what's the effect of IPPV?
Ma'am, it increases the interthoracic pressure, which results in decrease in venous returns and decrease cardiac output.
Good,
Yeah.
very good.
And decrease preload also, right?
Yes.
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 Preload, afterload, both.
All right, tell me the muscles of respiration first.
There is active respiration and passive.
Passive,
In
very
passive inspiration, we will have diaphragm mainly, and when it's active, we will have subclavius and sternocleidomastoid also involved. And then there is expiration.
Scalene muscle.
Yes, scalene to raise up clavicle.
Okay.
And then there is in expiration, the passive muscles is abdominal, elastic recoil, and accessory are abdominal one.
Very good. Okay, good. What are the nerve supply of muscles for muscles of respiration?
Diaphragm is by
C3 4 5
phrenic.
phrenic diaphragm. Yes, ma'am.
Yes.
It's mainly that.
Right, you are doing incision in the midline from outside to inside until peritoneum, from skin to peritoneum. What are the layers you are going to encounter?
In subcutaneous tissue, then superficial fascia,
Yes.
then
External oblique aponeurosis, then the sheet.
no, midline. Midline is
In the
directly
midline.
linea alba.
Upper midline. So they
Yes,
are
I'm
already
linea alba.
writing linea alba.
Yeah. Then peritoneum, extraperitoneal tissue, then peritoneum,
Yes.
and after that we reach the peritoneal cavity.
Yes. What if you're doing
Before
incision in the lower?
peritoneum is not it, there is something like transversalis fascia.
Fascia transversalis.
Yes.
Yes. So
In
if you're
midline.
Before peritoneum.
In midline.
In midline incision before peritoneum. I think so that there is transversalis.
Okay.
Right. And what about if you're doing incision in the lower 1/3 of abdomen? What layers
Yes,
would
ma'am.
you come across? Like just post for cesarean surgery
Cesarean
you're doing?
section.
Yes, C-section.
Skin, superficial fascia, anterior rectus sheath, then rectus muscle, then posterior rectus sheath will be deficient, and we will have fascia transversalis and then peritoneum.
Okay.
The main difference is posterior rectus sheath is absent.
Yes. It's in MRCS. Yes.
Yes, rectus muscle, rectus sheath, and fascia transversalis.
All right. What do you cut in herniorrhaphy? What is herniorrhaphy? When is it done?
Herniorrhaphy is
adults, it's
repair.
done.
Yes.
Repair of the hernia in adults.
Yes.
It can be with mesh or it could be just posterior wall strengthening.
Yes.
Both are called
Yeah.
herniorrhaphy.
Okay. So what is cut?
External oblique aponeurosis.
Yes. Which approach is used for this procedure?
Give
what
inguinal
method?
incision,
Very good.
or we can go laparoscopy.
Okay.
Laparoscopy if it's bilateral or recurrent.
When would you go for a yes when it's bilateral and recurrent? Then you can go for laparoscopy.
One
Yes.
other difference is in laparoscopy and open in the placement of mesh.
Yes.
Yes.
What is that?
In
I just
laparoscopy,
forgot.
in
Mesh is-
laparoscopy there are
yes.
two types of mesh placement. One is tape, one is tap. Tape is totally extraperitoneal, and TAP is transabdominal preperitoneal.
Okay.
And
Okay, and in open herniorrhaphy, neoplasty, it is placed posterior to the card.
yes, yes.
And in tap, it is posterior to the layers of the inguinal canal.
Yeah, in TAP, the total abdominal preperitoneal, we go through abdomen. So we are looking, we are incising the peritoneum from the abdomen, and we are placing the mesh preperitoneally. That means before peritoneum. And in TAPE, that is extraperitoneal, we don't go into the abdomen. We go into that hernia place, inguinal canal, and create we give carbon dioxide there and create space. And then after reducing the hernia, we place the mesh extraperitoneally.
Yes. He's right. In
Preperitoneal.
TAP, peritoneum is
extraperitoneal.
breached. Yes.
Extraperitoneal.
It's the same thing, extraperitoneal or preperitoneal, both are the same thing. It's the approach that is different.
In tap, we don't breach the peritoneum, right?
No, in TAP we go from the abdominal cavity. We directly go to the abdominal cavity, then we incise the peritoneum, and then we place the mesh.
It is too high.
And in tap,
Yeah, we don't need this for EMRCS.
This is too high, you know.
no,
This
I
for
think
your surgical.
they ask about.
No, they don't.
Okay. Okay, ma'am.
সম্রাট
Okay.
সৈকত ভাই
Right. 66 to 69 already solved. Dr. Ilmun told para-aortic and then internal iliac.
Yes,
What about the anal canal? Now tell me
Above
below dentate line and above. Yes, please.
Above it is
Internal
internally
internal
iliac.
iliac.
Yeah, and below it superficial
and
inguinal lymph
the
nodes.
superficial and
Yes.
inguinal.
Okay, good. Right, moving on.
नहीं लगता बुखार नहीं है.
What is he suffering from? Fever?
Yeah, I am having high grade fever. Just 1 minute.
That's why I thought you were sleeping. Squamous cell
No,
carcinoma.
I'm not sleeping.
Okay, he got disconnected. Squamous cell carcinoma of anal canal. It spreads
Superficial
to
inguinal.
lymph nodes. Okay.
If it's below dentate line, then superficial inguinal.
Yes. And if it's above?
And it also it goes to the internal iliac nodes if it is above the dentate line.
Okay.
And then
Usually,
it is
squamous
one
cell
of the
occurs
both
below the dentate line.
chemoradiosensitive.
Yes, squamous occur
Yes,
below dentate
yes.
line. You're right.
Yes. So the treatment
Yes,
should
yes.
be
Radiotherapy.
Chemoradiosensitive.
Yes.
It is one of
Chemoradiotherapy.
the
Chemoradiotherapy.
chemoradiotherapy. One is this one, and other one is esophageal squamous cell carcinoma.
Yes. We'll
That is also
discuss.
chemoradiosensitive.
It
Neoadjuvant
depends.
chemotherapy.
Esophageal carcinoma, upper 1/3, middle 1/3, or lower 1/3. So it's different. Which one are you telling?
Ma'am, but usually squamous cell carcinoma is most common in the upper 1/3.
Yes.
And in the middle 1/3 and the lower 1/3, there is usually adenocarcinoma.
Yes.
So I am asking about squamous cell carcinoma. I think it's squamous cell carcinoma. First choice is chemoradiotherapy, neoadjuvant chemoradiotherapy, and then after that we go for surgery, same as we go for anal carcinoma.
Yes. Now that you're talking about esophagus, tell me how long the esophagus is from incisors
40
till
25
Yes.
centimeter.
How many constrictions there are?
Ma'am, is it not 40 of the incisors?
It's I think 40.
40 centimeter from the incisor tooth.
Yes.
15, 22, 27, and then at 38 or something like that. These are 4 constrictions.
Okay. At
One
what
at
level?
First one
cricoid.
is first one
Cricoid.
is of the at the level of the cricothyroid, cricoid.
Yes.
Second
Then
one
arch
is
of
where
the.
arch of aorta,
Yes,
and
yes.
then where is the left bronchus, and then where it
Left one.
enters the through the diaphragm.
Right. So at what level it pierces the diaphragm?
T10, along with the anterior and posterior vagus nerve.
Okay. What is the blood supply of esophagus?
Till that.
Upper 1/3 is by inferior
Tell them.
thyroid arteries, and the middle one is by descending thoracic aorta branches, and lower 1/3 is by left gastric artery.
Lower 1/3 by gastric arteries, left gastric artery. Middle by inferior thyroid or thoracic
No,
aorta.
middle is by descending thoracic aorta, and upper 1/3 is by inferior thyroid artery.
Inferior thyroid. Okay.
So
Okay.
what is the lining epithelium of esophagus?
It's squamous cell
Pseudos.
carcinoma, certified non-keratinized.
Yes. So which layer is missing in esophagus?
Serosa.
Serosa.
Ascula.
Okay.
Serosa.
Yes.
Serosa. Yes, yes.
There are 2 MCQ in our RCS about it.
Yes.
Yes, serosa.
So does it make it easier for suture or makes it difficult?
Difficult.
Make
Then
it
there is
difficult.
increase anastomotic leak than any other
Yes.
part of the
Yes.
body. So what is the answer? 38 or 40?
40.
At the level of T8, T10, it's 40.
I know 40. I don't know. You can double check.
No, ma'am, because at T10 it enters, so that's the level. It should be 40.
Yes. 72.
Which is not in direct relation to posterior third of duodenum. Options are aorta, right kidney, right ureter, psoas. It's psoas. It's not in direct relation.
Yes. So relation of duodenum is important.
Yes.
They can ask you anterior relation, posterior relation, rubbish. You have to memorize them or look at the pictures to learn them. I always forget that. Right lung. So what is the posterior? What is posterior to the right lung hilum?
Zygus.
Yes, and what is anterior to the
Phrenic nerve.
Very good. These are frequently asked, so you have to
Yes.
remember them. So what's the blood supply of colon?
Transverse colon, middle colic.
Yes, that I've already given. I
Middle
forgot to
colic.
remove
Yes.
it.
Ascending colon is right colic.
What is the embryology of colon? I'm not saying transverse colon. I want large intestine whole.
Up to 2/3 of transverse colon, it is from midgut. After that,
Yes.
it's hindgut.
Yes.
Yes.
So blood supply.
So
Depend-
blood
Up to 2/3 it's by superior mesenteric artery, and from there onward it's by inferior mesenteric artery.
Yes.
Yes.
Okay. Let's see.
'75. Appendicitis, why there is a pain in central abdomen, afferent fibers to and from. Answers were parasympathetic vagus or sympathetic celiac plexus. Sympathetic celiac plexus.
No,
Okay.
parasympathetic vagus.
No, but
sympathetic
the
celiac
pain
plexus.
is due to sympathetic celiac plexus.
Why is it felt in the center, in central abdomen? First tell me.
Because of the
Because it's the
dermatome.
origin.
Same
T10
dermatome.
dermatome.
Yes. T10. Yes.
Referred.
Yes. Referred. What is the most common location of appendicitis?
Retrocecal, 71.
Retrocecal. Good. When
And then pelvic, 21.
yes. So when it is presented with pelvic presentation, it also presents with one typical symptom.
Diarrhea.
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 Very good. Very good. Yes. Otherwise, diarrhea does not.
Why it's not, Atia, why it's sympathetic celiac plexus? Is it not by the T10 vagus?
Vagus, what has to do with T10? I'm not getting. Both are involved, but the pain is by sympathetic and the stretching and all those were by parasympathetic. And by T10, they mean basically that the pain is also going to be in umbilical region. It has nothing to do with the vagus or that thing.
Good. So this is like after trauma, face X-ray is done, and there was no trauma on X-ray. Still, patient was feeling pain or something. So what would be your next option?
CT scan with 3D reconstruction.
Okay.
Yes.
CT scan.
Would it be CT scan or MRI?
CT
Ma'am,
scan
for
bones.
CT scan bones.
For bones, it's CT scan.
And for facial reconstruction?
We do the CT head.
3D.
Yes, ma'am.
We do the CT scan with 3D reconstruction.
Yes. Next question is also kind of similar. Just ankle X-ray and nothing on X-ray, and patient has pain. What would you next?
MRI.
Okay, what might be the problem? Sprain maybe?
Yes,
Could
ma'am.
be ligament injury. It could
Ligamentum. Yes.
or it could be bone injury. But MRI, I think, will diagnose both. Maybe. Have to look.
Why will
Yes.
not do CT scan here?
We have, because it can be ligaments and everything,
Yes.
and MRI
It
is
won't
sensitive for
help you,
avascular necrosis bones, and you have a talus and around your ankle. So wherever you have a bone which is more predisposed to avascular necrosis, we do MRI, like in hand for scaphoid.
Kind of, hello, Dr. Thia. Anywhere,
Ji.
if we are suspecting any kind of soft tissue injury, we will go for MRI,
MRI.
like in spine,
Yes.
ankle, spine, ankle, or something like that.
Even
Yes.
on face, I'm not sure. You people are saying 3D CT.
Ma'am,
It's in the
MRI.
MRCS, the MCQ.
Yeah, I know.
Yes, ma'am. In facial bones, we go for CT scan. One of my ENT surgeon told me that.
Yes. Lady with
Okay, sir.
total constipation, what investigations would you go for? So these were the options given: CT abdomen, colonoscopy, barium enema, small bowel study, or proctoscopy.
CT abdomen.
CT abdomen, yes.
Ma'am, isn't it depends upon the
CT.
whole scenario? Like,
Yes.
we also do
There
colonoscopy.
is BAS, then we will go for colonoscopy.
Yeah. In what conditions? Okay, tell me. You'll go for colonoscopy, or when would you opt for barium enema?
Barium enema usually we do for the to see any. No, we do the gastrograph in
Ma'am,
enema probably.
colonoscopy usually we do for if there is any bleeding. Then we
Okay.
go for colonoscopy. In obstruction, usually there is something like malignancy or other stricture or things like that. Then we don't go for colonoscopy. We go for CT abdomen that's more sensitive for these conditions.
If there is total constipation, we will not be able to do colonoscopy because
No.
there is obstruction.
Even yes,
We will have to look it
obstruction.
through CT. For
Okay.
And
colonoscopy,
it's
we need a
yes.
acute
clear
as well.
bowel.
Yes.
Yeah, and acute
As
as well.
well. And for colonoscopy, you have to prepare the bowels as well, and it's not
Patient.
ideal.
Yes.
Barium enema, again the same condition. It won't give you the whole picture, and you would have to prepare the patient as well. Small bowel
In
study
case
is
of
What
not
about
going
on
to
IBD, we do
solve.
barium
small?
enema.
Yes. Proctoscopy is just for up to sigmoid colon, so it's not going to give you enough information. Plus, you have to prepare the bowel as well. Small bowel study, it's useless. So, yes. Right.
In MRCS, they are saying if we suspect complex fracture pattern in ankle, like if we are suspecting posterior malleolar fracture, we use CT then. So I
Okay.
think the answer will depend on the scenario, right? That
Yes, definitely.
But usually the ortho people used to do CT.
In case of gastric atrophic gastritis, what would you see? What type of cells would there be?
macrocytic.
Yes.
Macrocyte.
In what conditions are you going to find atrophic gastritis?
Pernicious anemia. There will be
Yes.
decreased absorption of vitamin B12.
Yes.
फिर मैं खाता फिर वो खाना
What happened to Julkar?
I have no idea.
What did he say?
It was a personal
hungry.
conversation. You know, he was talking to his family member. Which drug is used in septic shock?
that was
Noradrenaline.
Punjabi.
Yeah,
Noradrenaline.
You people cannot understand that.
Okay, why are you giving noradrenaline?
Because
Because it's
peripheral vasodilation, and if it acts on
With
alpha-1 receptor,
constriction.
which causes
Vasoconstriction.
vasoconstriction.
Very good.
Yes.
Okay.
Hello.
Leon.
Yes.
Okay,
Okay. मुझे
81.
लगा मेरा नेट खराब है.
Which statement best? Okay, what is Duke's classification? Can anyone tell me?
A, B, C, D. In A, there is mucosa and submucosa. In B, there is lamina propria and muscular layer. In C, there is lymph node involvement. And in D, there is distant metastasis.
Okay, what is C1
If
and
the
C2?
In C1, there is going to be lymph involvement up to 2 lymph nodes
Yes.
locally.
Yes.
If there is more than 2 lymph involvement, it's C2.
Okay. So what is this? Describes Duke C colon cancer. Lymph node metastasis.
Lymph nodes involvement, local lymph node
Yes.
involvement.
If the
There
question
is
is
some
like
other
that, there is no.
classification.
That's astracolor when we
Yes,
include
yes.
C1, C2.
Astro,
Atya, if there is a question like that, there is no
astrocolor.
invasion through muscular scopia, but there
Yeah.
is one lymph node involvement. Okay.
C. Whenever your lymph node is involved, it's
It's
C1.
C.
And C1, if there is given
Ast-
C1. And when more than 2, then C2.
yes, yes, yes.
So what is the nerve supply of
And in
external
articular,
anal
it is
sphincter?
like that.
It's 2,
B1,
3,
B2,
4,
C1,
pudendal
C2.
nerve.
Okay.
Pudendal nerve.
What about,
Astropudendal
yes,
nerve.
what about internal anal sphincter? It is supplied by
Sympathetic.
Sympathetic. Sympathetic. No, it is sympathetic, I think so. नृत्य कंफर्म कर लें ये internal anal sphincter.
G.
I have low memory always.
this one is another simple one here, and again pudendal nerve is involved.
Epidural, yes, given for episiotomy, it is pudendal nerve S234.
Yes. And injury to this nerve will lead to what condition?
Incontinence. Incontinence.
Incontinence.
Prolapse of uterus in case of him.
It's pelvic sphincteric nerve in internal anal sphincter. So is it sympathetic or parasympathetic? I think it's sympathetic.
Parasympathetic.
Okay, para.
Surface marking of internal
Parasympathetic,
jugular
okay.
vein.
It's from the angle
Ear
of
lobule. It's from ear lobule to the medial end of the sternum.
end of the sternum.
Sternoclavicular.
Is it behind the ear lobe or in front the ear?
In front. Okay. Tibia injury with bone exposed. Tell me first what level of injury is this? And then
C. It's C.
what would you do next?
If it
We'll
is
do the grafting, skirt thickness graft.
Yes.
What C, Atya? I didn't get you.
Gastilo-Anderson classification
Gastilo-Anderson
for the
Gast-
open
Because
fractures.
Yeah.
bone is exposed.
Less
All
than
right,
1
then there
centimeter.
is, okay, another option. Vessels and tissues are in contact. Bone is exposed, but soft tissues injury is not there. Would it affect the management?
Yes, it would affect the management. There are three classification. Number one is like less than, there is open fracture, but less than 1 centimeter,
1
and
centimeter.
it is coverable. The wound is coverable. Then
Yes.
in 2, it's 1 to 10 centimeter open fracture, and the wound is
Not contaminated.
not
Not
coverable, I think.
No,
And
no,
in
not
C they have,
it is coverable.
secondary closure. By secondary closure.
but in C
Secondary
there is,
closure.
in C there is a blood vessel injury.
In
No, no.
there is
In C, there are
sections.
three
Three
sections.
sections.
Okay.
Yes. One is
C1,
like
C2, C.
doing regular dressing. We will cover with secondary closure. And 2 is covered by the skin graft or flap. In case of 3, there is involvement of the artery bones.
My question is, every time if it is there is exposure of the bone, it will be C, because if there is only 1 centimeter of lesion and the bone is exposed in that area, then will it be C?
Yes. Yes.
What? Yes.
Will be, because bone is
Okay.
exposed. And then next
Okay.
definition, you'll go ahead if the soft tissue injury is there or not. Yes, here she has given you sorry, vascular injury and requires repair. Okay, this is 3C. So here there is tibia head
Yes,
external
less than 1
fixation,
centimeter.
but now there is pus leaking from the wound, and the options were Staphylococcus aureus and S. epidermidis,
It's
etc.
Staph
So
aureus.
yes.
And
So
there is
what
a
is the
chance
most
of osteomyelitis in case of
yes
open
wound?
bone
Yes.
if it is not covered in time.
Okay. Question about CPP without blood pressure raised or whatever. Okay, what is CPP?
Cerebral perfusion
It's
pressure.
cerebral
Yes,
perfusion
how is
pressure,
it
ma'am.
calculated?
Mean arterial pressure minus intracranial pressure.
Very good.
And mean arterial pressure is calculated by 2 into diastolic plus systolic blood pressure divided by 3.
Yes.
And normal cerebral perfusion pressure is 70 millimeter of mercury.
Okay. How is it?
And
How does it influence cardiac output?
15%
Ma'am,
goes
when
to
there
the
is
brain.
Okay, good.
yes.
Next question is that there is enlarged lymph node in the femoral canal. From where the primary has come, or where is the primary? Yes, melanoma.
Melanoma.
Then primary will be
malignant.
Could be malignant
toe.
In the lower limb.
In anal
Yeah, in the
canal,
toe.
ma'am.
In the toe.
Yes, ma'am.
Anal canal.
I'm saying
Carcinoma.
lower
Could be
limb.
limb.
It's going to be superficial inguinal nodes, not femoral. Femorals
Yes.
are from lower part of your body, lower limb.
Yeah.
Through
I
popliteal.
suspect from the lower limb, most likely from the great toe.
Yes.
Don't know, but yeah.
It's T-shaped, right? The
Superficial inguinal.
the
Yes,
vertical one is
horizontal,
for the
vertical.
for
yes.
limb.
Yes, yes. And horizontal one is
it,
for cranial structures.
can it be squamous cell carcinoma? Can it be
Yes,
squamous cell
it can be.
carcinoma of the lower limb?
Yeah,
Yes.
it can be.
Could be.
Okay. You are saying only melanoma, that is why I asked.
It's malignant melanoma.
Yes, ma'am, it's malignant melanoma because
Australia,
they have
yes, it is
they are
malignant.
Why it's malignant melanoma? Australia has a sunny country, that's why.
It should have been
Temperature.
yes,
squamous cell
because
carcinoma,
of
or yeah. Or if they wanted it
Yes.
to be malignant melanoma, then there should be blackish lesions or something which could demarcate it to be.
Yes, yes.
Yes.
But I think squamous cell carcinoma would be more common in Australia.
Yes.
no,
And
I think we
malignant
searched
melanoma.
it. It was
It
basal cell. That's not what did we search it?
It was in Australia. They said it was it could be any cancer,
Yes,
malignant
ma'am.
melanoma. Because
It's
sun
more common.
exposure and UV light radiation is very high in Australia.
yes. That's why it could be like basal or squamous. Given
Okay.
a block to you.
You can't find anything above
Which
umbilicus or
level?
below.
T10. Yes.
T10.
T10.
Yes. The next scenario. So this one patient is overweight has high BP and thirsty, waking up a lot to pee, and random glucose is 11.9. So what was the problem? Yes, diabetes.
mellitus.
Yes.
Mellitus. Can you tell the baseline
Of
in case?
so simple MCQ, we will think that there is some complicated thing like that, and I'm sure I'm going to mark it wrong. The question
Why?
like that.
What is
According to
complicated
who?
here?
Ma'am, so simple question. Why are they asked? This is simple question.
They are giving you blood
I don't
glucose
expect any
random
simple.
11.9.
Yes, ma'am. Yes, ma'am. It is simple question, and
Zulka is for
I will
student
not
like
expect.
me.
No, Dr. Zulkarnain, you're getting it wrong.
No.
There is another problem in MRCS Part A exam. All the questions, 300 questions. Not all questions carry marks. You know, if you look at the total, it's not out of
Okay.
300. Some questions don't carry mark. They are just there, easy questions for you to
So
Yes,
enjoy.
ma'am.
if I
Very
mark this
seriously.
question wrong, I'm not getting any deduction in my marks.
So you should feel good about it, you know. All right,
Okay.
scenario with old man, smoker, very high FEVC and its ratio. So how would you know when the ratio is high and the ratio is low?
Less than
If it is
70%,
more
it's
than
obstructive,
80,
and more
Yes.
than 70%, it's restrictive.
It's
Okay.
80. Just one. It's
no,
80.
no,
It's 80, but
it is opposite.
tell me again, it's yes.
If it is more than 80, if it is more than 80, it is restrictive. It's then less than
Yes.
80, it is
Obstructive.
obstructive. And
Give examples of each, please.
other
Yes.
scenario is in restrictive, there is sarcoidosis and interstitial
Yes.
fibrosis.
Fibrosis, yes.
Very difficult name. Fibrosis,
And
interstitial
obstructive.
fibrosis, the things
Examples
like
of
that.
obstructive, please.
Common things like COPD and emphysema,
Bronchitis.
asthma, bronchitis, chronic bronchitis.
Okay, good.
There is one other scenario I faced yesterday, I think so, that in restrictive diseases, FEV1 is increased and FVC1 means both of them were given separately. FEV1 and FVC, both of them were given separately. Which one increases and which one decreases instead of their ratio? Can
Okay.
someone explain that?
In
We just
MRCS,
have
it's
to.
70%. That's why I said 70.
Yeah, sometimes it's 80. Mostly 80, yes. Anyone is answering Dr. Zulkarnain's question, please?
Because Zulka, you have to just calculate it.
Yes,
Put
it is it is
FE1
it
divided by just put, and it's going to be, you will get your answer. Then if it's more than 8.8 or like 80, it's
no,
restrictive.
Dr.
It's just less than that.
Tatya, listen to me please. Question was like that FVV1 and FVC, they were given separately, like to my options. In restrictive diseases, FVV1 is reduced, FVV1 is increased, FVC is reduced, FVC is increased. The question was like that. They did not mention the uh, ratio. They mentioned the separate things. Like here it is written that in restrictive diseases,
it's
FEV1
okay, I
reduced
got it.
and FVC it's significantly
I have
reduced.
answered. Dr. Zulkar,
Got
see
it?
the
Okay,
picture.
this was yes.
See the picture, you will understand.
Yes.
I got your question.
Yes. I'm reading that. I'm reading that. Thank you.
All right, tell me about the masses in lung. Which one is
There are
which?
two kinds of carcinoma, small
Yes.
cell, non-small cell. Small cells are centrally located, more common in smokers, and easily metastasize, and they are associated with paraneoplastic syndrome like increased ACTH, increased ADH, and increased and Eaton-Lambert syndrome. Then we have large cell carcinoma. Then we have non-small cell carcinoma. We have adenocarcinoma, squamous cell carcinoma. Adenocarcinoma is in non-smokers, and it's centrally located. Sorry, it's peripherally located. Yes, sorry. And squamous cell carcinoma is also centrally located, but how it differentiated from the small cell, it's that squamous cell disseminates lately, and it's associated with increased calcium level due to parathyroid-related hormone. And then we have large cell carcinoma, which is least common. It's around 10%, and it is present in.
What is the overall most common?
It's
carcinoma.
Adenocarcinoma, 40%.
Adenocarcinoma.
Yes, it's adenocarcinoma. Exactly. And in smokers, it is small cell carcinoma that is more common.
Yes.
Okay. A smoker has to undergo colon resection. So
Low molecular weight heparin.
Yes.
Low molecular weight heparin,
Along
compression
with
Low
by day.
molecular weight heparin.
Along with compression.
Compression.
Yes. Along
with
yes.
stockings.
Yes.
Stockings. Yes. What about a patient who has to undergo pelvic surgery? Any surgery in pelvic region, what would be the
Same.
very good. A patient who has to undergo hernia. Wait, let me finish. Hernia repair. It's not the same. You're not going to
We will
give
not
anything.
do this. Yes, we don't need to give anything.
Ma'am, I answered to previous question. Sorry, I answered to previous question.
Yes, very smart. So, if there is IV heparin, but the patient is still having repeated episodes of pulmonary embolism, what option would you go for? IV filter? Yes, IVC
Ma'am,
filter.
IVC filter.
Yes, because of repeated.
IVC filter. Repeated.
Yes, please. What if patient was taking warfarin originally, and now you have
even then IVC filter.
Yes. From this one, I meant from 94 one. This patient just suppose is taking warfarin, and you have to operate on this patient. How would you? When would you stop warfarin and or go ahead with low molecular weight heparin?
5 days before. 3 to 5 days before surgery.
Yes, yes. And how many? How long before surgery are you going to stop low molecular weight heparin?
6 hours. It has a
yes, yes.
6 hours before surgery.
Okay, what
6
level?
hours.
Iliac, common iliac bifurcation.
L4.
L4.
Okay.
5 is inferior vena cava.
L4.
Yeah,
Yes,
Atia, I think Faria is correct. Low molecular heparin is 12 hours and unfractionated heparin was 6 hours, I think.
Okay.
Maybe we have to check.
Okay.
In case of patient who has renal insufficiency, which heparin to give is better?
Unfractionated.
Yes.
That was the big one.
Yes.
Usually, we didn't give low molecular weight heparin. We give injectable heparin in an elective patient.
Yes, if patient is about to get to surgery, we use unfractioned. It's easy, reversible, shorter half-life.
External oblique, cremasteric by
Ex-
the
Yes, ma'am.
transversalis
External
Internal oblique.
fascia.
Cremasteric is internal oblique.
Yes, cremasteric internal
Yes.
oblique, and then the spermatic cord. Oh, sorry, internal spermatic fascia by fascia transversalis.
Yes.
Okay, tell me the contents of the popliteal fossa. They are asking the
Popliteal.
lateral structure, but I want to know the most deepest structure as well.
Okay, the most deepest is popliteal artery, then we
Very
have
good.
popliteal vein, then we have in center tibial nerve, and lately we have common cranial nerve.
Okay, and the lateral most is?
Common cranial.
Yes. Okay. If there is a fracture of
Neck of fibula, common cranial will be
or
damaged.
yeah, in the yeah, okay, good. Okay. A person got
19.
stabbed in the buttock and was not able to move ankle or toes. So the injury has taken place at which point, or which nerve has been injured? Sciatic.
Sciatic nerve.
Okay.
Sciatic nerve, ma'am.
What is the root value of sciatic nerve?
L4 to S3.
Yes.
Yes. Is there any other nerve which can present with the similar kind of symptoms? May not have been injured.
Superior gluteal.
No,
No.
cannot move
superior gluteal.
ankle or toes.
Okay. Can I move?
Superior gluteal is with gluteus medius. Gluteus medius has
Yes.
nothing to do with ankle
Common
and toes.
peroneal.
It's going to be common peroneal, yes.
Yes.
Perineal.
But because of the location, we went with the sciatic because common
Yes,
peroneal is
definitely.
at the level of popliteal.
Yes. So, wait, I'm sending another question. So there is a trauma, injured the right calf, which is tense and swollen. Lower leg is cold and pale. What is the injury? So what has happened?
Arterial damage.
Compartment.
Think
There
from
is
the right
Compartment
calf, which is
syndrome.
tense.
Yes.
Yes, ma'am.
Compartment
Or
syndrome. Because
not
in
damage,
arterial
Dr. Atia, maybe entrapment. Could be
entrapment,
compartment.
yeah.
Yes.
Because it is
There is the
swollen,
same
so it is compartment
MCQ.
syndrome.
There is the same MCQ in MRCS, and it has arterial damage in it.
That is for child.
Ma'am,
Supra.
Condylar fracture, yes, ma'am.
Yeah, that is child, then there is injury or yeah, entrapment. So here also could be entrapment, injury, whatever that. Dr. Zulkarnain was saying something. You want break?
No,
Yes,
ma'am.
ma'am.
Yes, she said yes. Because in like
Okay.
30 minutes I have to start my group A, B as well. But then if it's all right with you, I can come at 8 p.m. 4 or 5 more we
Okay.
can do because there are only 76 more left. So
Yes, ma'am. We will.
Can't we do tomorrow, ma'am?
tomorrow we'll do 2019 September.
Okay, ma'am.
I had meeting in the morning, otherwise I had the plan to do it early. So then I have free enough time, because of my...
Okay, ma'am.
So parotid, tell me about the parotid gland. Why is it important that there are structures which pass through the parotid gland? Can you tell me the
Yes.
structures, please?
Most superficial is a superficial nerve, and then
Okay.
there is retromandibular vein, and then you have
Yes.
external carotid artery, deepest one.
Yes.
And most common damage, facial nerve, most superficially damaged is greater auricular nerve,
Common.
and if in case of a repeated surgery, we will damage the facial nerve.
Yes.
These are the questions they ask.
Right.
And
And what about the lesions? Benign and malignant. Which one is more
benign will have no
associated?
facial,
Okay. Yes. No facial nerve involvement.
malignant will have facial nerve involvement.
Right.
Pleomorphic adenoma, most common.
Yes.
Yes, ma'am.
Associated with smoking and elderly. Which one is it?
Wharton's.
Very good.
And adenine cystic carcinoma has perineural invasion property.
Perineural invasion. Very good.
And also Warthin tumor is bilateral.
Yes.
No.
Okay.
Warthin, yes, it is. It is.
Not always, not
Ward,
always.
The most common cause of a
Warthin,
bilateral
sorry.
parotid enlargement is sarcoid and mumps.
Mumps, yes.
Mumps.
Warthin can be,
But
can be
if they-
bilateral, but not always.
Yes, but usually they ask about when it is bilateral. I solved an MCQ and I was wrong, so I remember that.
Okay. We'll check again.
Which
This
is
one
bilateral?
is also similar. Parotid
There's
again.
4 causes. Parotid, 4 causes of bilateral parotid. Sorry, Warthin tumor. Then it is sepsis and mumps, and there is some other autoimmune disease. I forget. There are 4 causes of bilateral
Sjogren's.
parotid. Yes, Sjogren.
Okay, tell me.
So what
if
is the
this-
answer of this one? Enter to the ear.
It can be anything. Depends upon the option. No?
Yes, and then depending upon the age of the patient, the mode of presentation. All right, there is a mass anterior to the ear, but is it painful? Is it inflamed? Could that be mumps?
Yes, ma'am.
So what is the
Yes,
age
ma'am.
group of the patient? How is it presented? So you have to tell accordingly. If it's painful, what could that be?
Mumps.
Abscess.
Okay.
Abscess.
If it is
or-
painful, as mumps.
It can be
Abscess is
that
not
thing. Stone,
Yes.
obstruction, secondary to stones can be
obstruction,
painful.
Yes.
Tendinitis.
Yes.
Can
Or
you
it can be
tell me
mumps.
where the duct opens? At what level?
Second molar, upper.
Second molar.
Upper.
Second molar.
Very good. Very good. Yes. This is
And
something Dr.
this duct
Christopher
is
has.
called
Yes,
Stenson or
bilateral.
Warthin. What is it is called?
Stenson.
Stenson.
Warthin
What
is
is
for
it same?
submandibular. Stenson for parotid, Warthin for
It's
submandibular.
Stenson. Okay. I
So
will forget
whoever
that
was
always.
saying, Dr. Zulkarnain is correct. It's bilateral.
Okay, ma'am.
Which
Now
one
remember.
bilateral?
Warthin.
Adenine
Warthin.
cystic.
Warthin
Warthin's
tumor.
tumor, like he said,
Warthin.
it's bilateral. So you
And
have
it is in male. All other are in females.
okay. And
Other
smokers.
sarcoidosis and Sjogren, they are in female, and it is in
Yes.
males. Warthin tumor in males. More
Yes.
common.
All right, we'll stop at 6. So we'll only be left with 70 MCQs. All right, okay. All right, microbiologist contacts the urology consultant and there has been some infection in the ward. So MRSA, yes. What should be the,
Or it can,
yes. Now this
it can be
patient,
Clostridium difficile.
sorry.
Depends upon the scenario. Contact.
It cannot be Clostridium difficile. Why? Because patient is not, this is associated with the use of antibiotic and mostly in GIT.
Not Warthin.
So this most likely could be MRSA. So how, tell me, how should it be managed?
MRSA if
If
carrier,
it's
then
MRCS,
nasal
very nursing.
origin.
Yes.
Yes.
And if infected with MRSA, then vancomycin.
Yes. And what
And
is
some
other protocol that you have to follow?
barrier nursing.
Yes, very good. The one who is suffering should be kept isolated, like now you're following for COVID-19, more or less. Contact precautions, yes. Okay,
In
good.
Clostridium difficile, they will give the scenario that patient had some antibiotic and now patient has
Yes,
diarrhea.
yes, yes. And mostly patient will be post cholecystectomy or has, like, you'll know that patient is, because this is like post antibiotic, you'll have this.
So this answer is
Yes, ma'am.
MRS.
Sorry,
So what is the answer of this question?
MRSA. They have written it. All the precautions, isolation, everything you have to follow accordingly. Okay. So right side of the face is dry and lack of celery, something which autonomic ganglia is responsible. Dryness of the face.
So stellate
Ma'am, dryness.
or pterygopalatine?
Yes, ma'am, dryness is stellate.
Okay.
No, side of face is stellate. It's in that Horner syndrome, as we say. But
Okay.
ciliary is something I'm not getting. Are they talking about the ciliary muscle? If they're talking about the ciliary muscle, then it's
No, no, no.
another ganglion.
No, I don't think they're talking about ciliary muscle. Since, yeah, it's like incomplete. I don't know what to say. Autonomic ganglia. Okay, which one is autonomic ganglia?
There are parasympathetic and
Stellate.
sympathetic.
Yes.
Sympathetic is stellate and parasympathetic is the rest, pterygopalatine,
Yeah.
ciliary,
Yeah.
submandibular, and otic. These are the ganglions.
True. So this one could be which one? Parasympathetic. I don't know. I don't know.
Could be
Maybe.
stellate because stellate ganglion is blocked if the patient have hyperhidrosis.
Yes.
But if they say the eye is dry, it will be pterygopalatine. But they are
Yes.
saying face is dry.
Face is dry, so could be. Dr. Osaf is saying satellite ganglion, maybe satellite ganglion. I don't know. He would know. Could be, yes. ECG interpretation. Can anyone tell if there is anterior MI, anterior wall MI, what would be in the ECG?
ST elevation in V4, V5, V3, V4. Anterior
Okay.
wall.
And inferior MI?
2-3 AVF.
2-3 AVF.
Hypokalemia?
Long QT interval.
Okay.
And T will be depressed. U inversion may be there.
Yes. Total are 76. So one more will do, and then 70 will be left.
And in P, there are multiple list of changes.
Yes.
There could be no change. There could be S1, Q3, and T3 change.
And
there could be right bundle branch block, right axis deviation.
Yes.
And then that V1 to.
What about T wave?
T wave
inversion.
Inversion. Yes.
Inversion.
And there is one thing that we did, V1 something.
Yes, that is R wave in V1.
Yes.
For long door wave.
And the P wave is depressed, I think.
P pulmonale.
P
It is
pulmo.
PQRST. It is PQRST. P for P pulmonale, Q for clockwise rotation, and R for this was RBB. R1 R prolonged R wave in V1, and there was something else with the R, right axis deviation.
Right
And
axis deviation.
as
Yes.
for
And T
yes,
wave
right axis
inversion is in
deviation.
V1, V2, V3.
Yes, yes, exactly. And as for S3
Yes.
and T wave inversion in
Because
V1,
that
2,
was
3.
another recall, this T wave inversion V1, V2, V3.
Yes, this is
Good. She has written it all.
T wave inversion.
Good.
PQRST.
Okay. What should be given in case of brain metastasis? How should it be managed?
Steroids. We give steroids.
Yes.
Steroid.
Yes.
Steroid.
Yes.
In pulmonary embolism, most common is sinus tachycardia. Remember, most common
Yes.
is sinus tachycardia.
Yes. All right. I'm sorry, but I have to stop it here because in less than 20 minutes I have to
No
join my
problem,
group.
ma'am. Thank you very much.
Thank you
It
so
was
much.
really,
Yes, ma'am. Thank you so
really well
much.
Thank
productive.
you.
So if
Thank
you
you
would
very much.
want, then I'm available at 8 p.m.
Yes, ma'am. We will be there.
So if, yeah, and then I'll
Inshallah.
send you the link and you can join like
Inshallah.
this and we can finish it today. So that if you don't want me to start early, but then it's better to start early, September 2019, because what I feel that since you people are giving in September, exams which had taken places in September are more likely to come recalls from them than this one, January, if you understand what I mean. So I'll be focusing more on on September exams, maybe 2019 and 2018
Okay, ma'am.
also. I will cover, but not all of them, maybe not. Or if you want, then I will go through it, all of them. Yes, all right. Allow
Ma'am,
me to
thank
end
you
now.
very
Yes,
much.
thank you
Thank
so
you so
much.
much.
So we'll meet at 8 p.m. UK time. Thank you.
Inshallah.
Yes, ma'am.